Thank you. Someone was commenting probably a tiger or some other picture might have been better. Anyway, thank you all for coming tonight, and Mary for that kind introduction. Let me take you back a few years to my clinic room, where I was waiting to see Andrew, a young triathlete, a dynamic person who was referred to me with a suspicion of arthritis. So the referral notes painted a picture of a successful businessman with a true passion for the outdoors and for physical activity. So that's the reason behind my surprise when I saw Andrew being wheeled in. Okay, yeah. So he looked much older than his stated age, visibly depressed and in significant pain. The pain was initially attributed to the significant amount of physical activity that he was engaged in. But soon, the pain would become overwhelming, and he was unable to walk or even take care of himself. He was eventually diagnosed with axial spondyloarthritis, or AS. For many, probably this is the first time you're hearing this term. AS is a chronic inflammatory arthritis that predominantly affects the spine. It affects 1 in 100 Canadians. A lot of these patients also have inflammation in the eyes, manifesting as iritis or uveitis, in the skin as psoriasis, and in the gut as Crohn's colitis. The relentless inflammation can lead to spinal fusion, resulting in chronic pain, lack of mobility, disability, and a progressive stooped posture. These chronic complications are not just limited to the musculoskeletal system. In a large population-based study involving nearly 25,000 AS patients and 100,000 controls done right here in Ontario, we identified for the first time a 60% increased risk of dying from strokes and a 35% increased risk of dying from heart attacks. Not only that, despite the availability of many advanced therapies these days, nearly 50% of these patients do not respond to treatment. This is because we don't truly understand the root cause of AS. AS is driven by a complex network of cells and molecules that it is very difficult to pinpoint exactly what is the root cause of disease progression. But here at the Krembil Research Institute and the Schroeder Arthritis Institute, we have the teams and the tools to tackle such big questions. Owing to our multidisciplinary approach, as others have alluded to, and the availability of advanced techniques, we can pursue high-risk, high-reward projects. And I'm proud, as the division head, to state that rheumatology in Toronto has been ranked #1 in North America for impact, publications, and yes, you can clap. Thank you. So one of the examples of high-throughput techniques that we use comes from single-cell sequencing. Our immune system contains numerous cells, some of which we know today, but many yet to be discovered. And each of these cells produce many, many molecules. It's not possible with traditional techniques to study each of these cells and the different permutations and combinations with the molecules they produce. So we have to rely on techniques like single-cell sequencing. That has really changed how we approach studies in immunology. With a small amount of blood and with a single experiment, you can actually get information on all the cells within that blood sample, as well as the molecules that they produce. So we can easily predict what the immunological makeup of a patient is, right, even before treatment starts. So with these cutting-edge technologies, we made a discovery, a new drug target. This is called MIF, or macrophage migration inhibitory factor. Now, this is a patent-pending discovery made right here at the Schroeder Arthritis Institute. MIF drives inflammation in all the target tissues that I mentioned earlier, the eyes, the skin, the spine, and joints in patients with spondyloarthritis. So we went ahead and blocked this molecule with a new inhibitor, a MIF inhibitor drug that actually reversed all of these manifestations in a preclinical model. Right now, we are working with a company in Austria to take this to clinical trials and benefit our patients with AS. So in rheumatology, we work with industry quite a bit, and we are now working with Novartis to bring CAR T-cell therapy to Canada for the first time. This will benefit patients with multisystem autoimmune diseases, such as lupus, myositis, vasculitis, and systemic sclerosis. In another world-first discovery, we identified that the use of biologic medications, TNF inhibitor, in this case, to reduce the risk of spinal fusion that I mentioned earlier by as much as 50%. This was a paradigm-changing discovery that has resulted in significant changes in the way we treat patients with AS. We also identified a window of opportunity that has led to an emphasis on early diagnosis and early treatment of these patients. So let's go back to Andrew. Andrew also faced a major decision. These were very early days, and we didn't know what the complications of biologic therapy would mean at that time. But he decided, he trusted in science and decided to go ahead with a biologic therapy. And in no time was he not just on his feet. You can see him completing his Ironman. And as of today, he has done 3 Ironmans already. And Mary, that's his family there, right by the side. What you see at the top middle is a full-page Globe and Mail article chronicling his story, as well as our discoveries in this space. So just like Andrew, we too need to take risk. We need to be bold. We need to invest. We need to push the boundaries of science so that we can help patients like Andrew reclaim their lives. And right here, Krembil Research Institute is the best place to do that. Thank you.
Thanks very much, Nigil. I actually like that picture where you talked about the complexity of disease and you had all those roads intersecting. I'm assuming that was Toronto traffic, right?
Before Taylor Swift.
Before Taylor Swift, okay. That story of Andrew is remarkable. Like, it almost seems miraculous. Like, is that a once-in-a-lifetime kind of story? Or, I mean, how often would you see something like that?
Very good question. You know, compared to what we were facing 2 decades ago, where we had just anti-inflammatories for treating these patients, absolutely the field has changed. We have so many options for treating patients. However, we still have major challenges. And as I showed in that picture, everybody's not an Andrew, right? So 50% of patients have excellent response. Another 20% will have a little bit of response, but still around 25% don't have a response. So you have to keep on trying to find the right drug for the right patient. So if only we had a good algorithm by which we could have predicted this right at the onset, we could have chosen the best drug for each patient. And then there are patients who will not respond to any treatment, and that's where the discovery is important. And hopefully, therapeutic agents like MIF inhibitors might change that as well. Thank you.
But I'm surprised. Sorry. You said 50% have an excellent response?
50% have an excellent response, yeah.
So then it's not uncommon for someone to actually make a dramatic improvement.
Absolutely.
Wow.
Absolutely.
Okay. Thank you very much,
Thank you.
Nigil.
Thank you.